Welcome to the second seminar of a seminar book series organized by the Transforming Care Network. I wish you a very good day. And this is our start for this morning. It's a seminar. Well, we will discuss an interesting book that is edited by Tine Rostgaard, John Parsons and Hanne Tuntland. The book is titled Reablement in Long-Term Care for the Proactive and Future Directions, published by Policy Press a few months ago. I'm Costanzo Ranci. I'm chairing the Transforming Care Network, and I'm very pleased to introduce you the speakers of this seminar. I will follow the order of the program we have. Tine Rostgaard, who is one of editors from Rostgaard University and Stockholm University. Then Hanne Tuntland, Western Norway University of Applied Science. Amy Clotworthy, University of Copenhagen. And John Parsons, University of Auckland, New Zealand. A discussant and very pleased to introduce Caroline Glendinning, Emeritus Professor, University of York, UK. Thanks for all of you for participating in this discussion. We will have short presentation from the editors and contributors of the book. Then Caroline will give her comments to this, and then we will have plenty of time for comments and questions from the public that we hope will be very rich and very important to interesting also to the authors and to the public. Okay, so I think that we can start. So Tine, you can take the word and start.
Thank you very much, Costanzo, and very happy to see you people here, all you people here this morning. You can see the program here on the screen. So I will first talk a bit about the rational perspectives of reablement. Why is it an interesting and innovative new policy and practice? And then Hanne, who's also a co-editor of the book, will take over and talk a bit about what are the features of the particular reablement model. Amy, who's a co-author of the book, will present her chapter, which has been discussing reablement from a critical perspective. And then John Parsons, co-editor and also co-author of the book, will present what are the outcomes for the client and also what cost-effectiveness perspective is there from reablement. And then, as Costanzo say, Caroline Glendinning will discuss the book. And then we are looking forward to comments and questions from you in the audience. We should also introduce David Palomera, who's member of the Transforming Care Network management team, and he's very kindly the technical host today. So, as I said, I will just speak shortly about the rationale and perspectives of reablement. The book addresses this in the first chapter, but before going into that, I thought I'd just present to you the overall aim of the book, which is to critically investigate, but also advance the knowledge of reablement in an international context. And we were interested when we got together in the Reablement network, which is a very large and international research network that Hanne is chairing. We have a lovely website also where you can find information about reablement in the various countries. But we were interested in the network in understanding what's the fundamental idea behind reablement in both of terms of policies, but also the practice. We were also interested in investigating what different models exist in different countries. We made a Delphi investigation in terms of what were the shared characteristics of the model, but we could also see that there were various ways of implementing it across countries. And then, of course, very importantly, also how these models work and what were the overall consequences for users, but also their families and those providing care and societies more overall. So in the book, we present empirical evidence on reablement, and we also hopefully have contributed to the theoretical understanding of this new practice. So turning to the drivers and rationale, not surprisingly, I guess, for most people, aging societies are putting quite a lot of pressure on various welfare states in terms of the increasing number of older people. We know that mortality and morbidity is affected in terms of the aging patterns. And we know that we have some patterns of compression of morbidity, but we also know that with the increasing number of older people in our societies, there will be more people who need health and social care. We also know that many people today would like to age in their own home and not move into a nursing home. So this is projected in across countries to lead to an increase in age-related spending. I've just put in some OECD figures giving an average across OECD countries in terms of the expected increase in health and long-term care expenditure. And there are some different scenarios. One is where you can keep medical cost quite low, and the other is a more cost-pressured scenario where you can really see the increase in the expected expenditure towards 2060. Of course, across welfare states, there are variations. Some welfare states already today spend quite a lot of GDP in terms of long-term care. The Nordic countries, for instance, are quite high spenders. So it will affect countries differently, but it will put a lot of pressure also on informal care, for instance. So the demographics are certainly important in terms of aging, but also we know there are changes in the household composition, so that people don't live together across generations, but they live more in single generation homes. We also know there are cultural changes, that people prefer formal care over informal care. So there is the expectation that welfare states will provide some formal care. Also, we know that more and more there are preferences for person-centered care, which takes into account the individual needs and desires. So Reablement has, these are the drivers, you can say, and the rationale for Reablement is that you can address some of these drivers, but also we believe that it's also a way of minimizing risk for older persons in terms of making them adapt to the changes that will occur in old age, and also to help them prevent certain dependencies. If you take a more societal perspective, you can also say this is a policy tool that actually gives welfare states some new capacity for managing and addressing the new societal risk that associated with population aging. So it gives them some means of addressing in terms of policy. We can also see that Reablement is in accordance with the current aging paradigms and policy trends. So just to give you a few mentionings of overall the active aging discourse, that you should stay active in old age, and you should try to preserve your health and your functionals in terms of physical, social, psychological, and so on. But it's also part of, for instance, the EU Commission Social Investment Package of 2013, where Reablement was actually singled out as an interesting and innovative policy. And it's also in accordance with the UNICEF's Vienna Ministerial Declaration, emphasizing that member states should be enhancing the potential of older people for the benefit of societies and increasing their quality of life by enabling their personal fulfillment. So the perspective of Reablement is that we have aging societies, and we need to have more responsive long-term care systems. So we believe that Reablement has the promises of introducing or enhancing the sustainability of our welfare states by addressing policies that can keep cost of long-term care down, considering long-term care more as an investment, just like you would invest in childcare and overall labor market policies. It's also a policy that has very clear notions of prevention, and it's a policy that increases the competences and resources in terms of the individual, but also in terms of staff, for instance, in working together. It's a policy that also can introduce some aspects of fairness in terms of equality, affordability, gender balance, and unburdening informal carers, and also addressing the care drain, which we know can affect some countries in particular. And lastly, we think there are also aspects of quality in terms of it emphasizes a professionalized care approach, that various disciplines are integrated and work together, that the older person participates. Hanne will address this more in a few seconds, but also then empowers the older person and provides a person-centered approach. So all of this, we think, can be achieved in the Reablement approach. Thank you very much.
Thank you, Tine. I think we can give the word to Hanne. Hanne?
Yes.
Yes.
Just share my screen.
Can start sharing. Yeah. Okay, great. You can go. You can guide.
Yeah, thank you. Hello, everyone. Chapter 2 in the book, our book, describes the most common model features of Reablement. Although variation, there are some common Reablement model features across nations and regions. So I will briefly present some of these common model features in order to give a more thorough understanding of what characterizes Reablement and how it is different from our traditional approaches to care. So attempts to unpack what might be successful components of Reablement are in their infancy. However, some systematic reviews have started to document this. So here are the model features coming up. The first component is being a person-centered intervention. The core idea of a person-centered approach to long-term care for older people is to organize services in accordance with what is important to the individual and center around the individual. So in person-centered practice, the question raised to the client is, what is important to you? Being a person-centered intervention is considered to be a key success factor in Reablement. In a familiar setting, the fact that Reablement takes place in a familiar setting is a valuable feature of the intervention and assumed to be an important success factor as well. When individuals are engaged in real task performance, in real places with real objects, then the task performance is really contextualized. And this is the case in Reablement. A man who wants to improve his skills in preparing a meal would do so at home under the guidance of a Reablement worker. In his own kitchen, with his own kitchen utensils, he would prepare a dish that he wants to be able to prepare. This is in contrast to hospital-based rehabilitation, which has few situational elements, making the rehabilitation process less contextualized and authentic. Goal setting. In Reablement, it is essential that the individual defines his/her goals in collaboration with Reablement care providers. Goal setting allows to identify and prioritize daily activities that they find difficult to perform and important to improve. Or, as it is phrased in the Norwegian Reablement approach, what activities are important in your life now? Focusing on the individual's goals function also as a unifying platform for the interprofessional team. The goal setting promotes motivation, which may also be a key to success in Reablement. Holistic approach to goals. Being a holistic intervention means, in this respect, taking into account various aspects of the client's health and functioning, and to incorporate these aspects in the client goals. To increase or maintain an individual's independence in meaningful daily activities are often considered to be the most essential goal in Reablement, and goals relate often to self-care and mobility. Such as, however, goals may also be leisure activities and of psychosocial character, such as doing handicraft or being able to visit friends and family. This is, however, contested, as it is argued that having a social life is rarely included in the goals of Reablement programs. Nonetheless, in order to Reablement to fully be a holistic intervention, more attention should be given to the social needs of the clients. Okay, now it won't work here. There you go. Multimodal intervention components. Reablement is a multimodal intervention with application of several components. The most common intervention components to reach client goals are in a systematic review by Boomer et al. From 2022, found in declining order to be ideal training, physical and/or functional exercise, education, and environmental adaptations. Ideal training was the most common intervention component, of which the review found promising results. Physical and/or functional exercises focus on physical activity by means of training muscle strength, balance, endurance, and motor skills. Education means that clients, for instance, are taught self-management, building confidence, and problem solving. Finally, environmental adaptations imply use of assistive technology and home modification. The review concludes that it seems like effective interventions on average include more diverse components, on average 4 components. An intensive intervention. In general, Reablement is an intensive intervention based on efforts provided by the professionals in the Reablement team. The degree of the intensity is based on the frequency of home visits and individual training, as well as the duration of the intervention. The intensity may be 5 days a week for 4 to 6 weeks. If the approach is diluted with weaker intensity, it is uncertain whether the intervention would still have an effect. An interdisciplinary approach. The interdisciplinary Reablement team often consists of Reablement care workers, registered nurses, occupational therapists, and physical therapists. However, the actual skills mix of professions involved in the Reablement varies between countries and communities. On average, effective intervention had a more diverse team of healthcare professionals than non-effective interventions, according to the systematic review by Boomer et al. From 2022. An explanation for this might be that in a diverse team, there are a broader base of knowledge, skills, and resources available, allowing various viewpoints to be applied on a problem. So, to conclude, these are the common features of Reablement and also some of the success factors. At the same time, these are also the effective features of the service model. Thank you for your attention.
Thank you so much, Hanne. Amy, the floor is yours.
Thank you very much, Costanzo. I'm just going to share my screen. Yeah. It's coming slowly, I promise.
No, it's fine. Okay, you can go ahead.
Great, thanks. So my name is Amy Clotworthy, and this part of the presentation is based on Chapter 10 that my former colleague Rudy Westendorp and I contributed to the book. And based on our collective experience in researching Reablement, Rudy and I explore the question, how could Reablement programs more effectively achieve their intended outcomes and enhance aging adult social engagement? So our chapter takes its point of departure in a 2019 critical systematic review of literature from 2005 to 17. In this review, Daniel Doe and his colleagues studied a range of Reablement programs being implemented worldwide. And based on how Reablement was defined by leading scholars in the field during this time, the author's review and analysis ultimately identified 9 quote-unquote essential features. The most frequently cited features at this time were improving an older person's functionality and maximizing independence. Although personal goal setting was considered to be important, it was not always. And in fact, goal orientation was only the 5th most cited essential feature of Reablement. So in our chapter, Rudy and I outline why we think this is problematic. Specifically, in the transition from theory to policy and then to practice, we argue that Reablement programs seem to have lost sight of their central purpose, which is to support older people's preferences and priorities with regards to being more self-reliant and socially connected. In Doe et al.'s review, the authors suggest that when personal goal setting is involved, it should focus on specific client needs and be driven by the client's aspirations and context. And such an emphasis echoes the original conceptualization of reablement. One of the earliest versions from 2002 in the USA was grounded in principles adapted from geriatric medicine, nursing, physical rehabilitation, and psychological goal attainment. And this refers to the belief that people are more likely to adhere to treatment plans if they're involved in setting goals and in determining the process for meeting these goals. And of course, research suggests the process of goal setting can often present challenges, particularly with frail older people. But in terms of how reablement programs are currently organized, operationalized, and understood in practice, we believe that they should first and foremost recognize the heterogeneity of older people and support them in reaching their own self-identified goals. This was the original intent of reablement, and as we argue, undeniably its most essential feature. But in order to effect substantial and meaningful change, and to ensure that older people's individual needs, priorities, and goals are acknowledged and supported, we also believe that there's a key logic that would help to make reablement more effective. And here we take inspiration from philosopher David P. Ellerman's theory of unhelpful help. The term unhelpful help means that any help given must be non-distortionary. In other words, the helping intervention should not change what the doer would do, given sufficient resources, and it does not distort the original motivation of the doer. So this is similar to the principle of client self-determination, which is often applied in clinical practice and community care. But in particular, Ellerman suggests that professional judgment and assistance should be based on an individual's intrinsic motivation, which is not open to intentional and deliberate choices or external factors. And this is because such motivation comes from a person, the doer's, unique sense of identity and history of lived experiences, which cannot be externally changed or acted upon. Ellerman states that the doer's actions will be guided by their knowledge, conceptual framework, values, and worldview, and not those of the helpers. So in our chapter, we suggest that Ellerman's 5-point framework for the helpers trying to provide this autonomy-compatible assistance could help the reablement professionals. In our alternative conceptualization, we envision reablement as a program that, rather than providing the more traditional form of help to self-help to support functional ability and independence, instead it emphasizes offering this unhelpful help to promote self-choice and autonomy. But what does this mean? Well, fundamentally, we believe that rather than a paternalistic linear approach to knowledge translation and transfer, or even a flexible training plan, the work of reablement should reflect a messy, open systems approach. An approach that's based on associative thinking, complexity, and a lack of focus on achieving a particular predefined outcome. An approach that's defined by and continually adapted to the older person, and possibly even blended into other care services. So we suggest that when the older person is able to define both the problem and the desired outcome, they assume authority for and control of their reablement trajectory. And research has indicated that gaining such a sense of purpose and empowerment promotes autonomy and social engagement, which consequently has a positive impact on longevity and quality of life. So we believe that the health professionals should ask why it's important for the older person to participate in reablement, and then really listen to their answer. This will enable the professional to move away from a focus on achieving set outcomes, such as reducing the individual's need for home care services in the first place, and will also move away from the need for benchmarks and potential economic benefits. So, in line with Doe et al.'s review, other biomedical research has found that enhancing older people's participation in goal setting and making decisions for themselves is an important yet often missing aspect of care. And some qualitative research in Norway has also found that, specifically with regards to reablement, including the individual's life history and existing coping strategies in the training plan can be essential to its success. So the reablement professional should try to recognize the individual's self-identity and unique personhood. And with this perspective, the professional helpers can support the doer in what they want to accomplish. And these goals should be grounded in the doer's current needs and resources, both physical, mental, and social, as well as their individual circumstances, personal desires, and local context. The use of a goal facilitation tool in the assessment of an older person's needs during home care has been shown to significantly improve outcomes as a consequence of individualized services tailored to the successful identification of the person's goals. But most important, as Gyosa et al. Suggest, we believe that reablement providers should take time to see beyond age, engage in relational communication, facilitate participatory goal setting, and collaborate more effectively with a person and family-centered approach. So the research in this book indicates that a central driver of many reablement programs worldwide has been a focus on productivity, cost savings, and functional independence. But both in terms of implementation and practice, as well as on a higher societal level, we suggest that government officials and health professionals should put more effort into building stronger, more inclusive communities of care. Such communities would include institutional infrastructures that acknowledge and value human complexity, that is, the irrationality, limitations, and messy systems. They would also promote inclusion and reflect a variety of sociocultural perspectives on aging. But most essential, such communities of cares would include health professionals who are able to help aging adults balance between optimizing capacity and accepting losses in their everyday life. So, in conclusion, putting economic markets and organizational ambitions before people's needs and priorities can be problematic, as it erodes trust between the professional and the client. And the risk is that instead of maximizing their learning abilities, the older person's resources become suppressed. So in terms of how reablement programs could more effectively achieve their intended outcomes and enhance aging adult social engagement, our research suggests that it's necessary to acknowledge both the potentials and vulnerabilities of later life. This will help to support older adults' engagement while encouraging others in society to recognize older people as valued participants, active on their own terms, and as moral agents in their own lives. Thank you.
Thank you so much, Amy. Okay, we go to the last presentation for today. John, you can take the floor.
Yep, hang on, sorry.
Okay, thank you so much.
Right, thank you.
Yeah.
Good evening from New Zealand. Good morning to the rest of you. My name's John Parsons. I'm one of the co-editors of the book, as Tine said. So what I'm doing today is talking to you about two of the chapters. So one of the chapters that looked at client level outcomes and one that looked at cost effectiveness of reablement. So the first of these, which is chapter 5 in the book, does reablement improve client level outcomes of participants, an investigation of the current evidence. So I co-wrote this chapter. So Jill Lewin from Curtin University in Australia, she was the first author, and myself and Hilary and Silke were the other authors on this book, on this chapter. And I had two aims. So looking at the evidence around what individuals gain from participating in reablement, and also exploring why the evidence is limited and how that situation can be improved going forwards. So it wasn't a formal systematic review, but it was a review of the available evidence. We included a number of the systematic reviews that had been published at this point, and what we found, most commonly reablement research had evaluated activities of daily living, physical function, quality of life, and overall both the individual articles and the systematic reviews that had been published to that point stated that the results were weak. They were promising, but they weren't conclusive. There was some evidence that reablement had an impact in improving quality of life, improving mobility, and improving daily functioning. And the evaluation results that we looked at tended to be more positive than the perhaps more robust research designs. And it was really clear that some individuals benefited more than others when they were part of reablement evaluation or reablement research. And finally, that there was no evidence that the benefits from reablement were less than usual home care. So that was good in terms of proving that it did no harm. But yeah, the results themselves were no more than promising at that point from the evidence we were looking at. There were two systematic reviews that were published more recently. The Boomer systematic review was referred to in the chapter, but we didn't actually explore the findings because it came too late. And the even more recent one by Bennett in Health and Social Care in the Community from last year, that was after the chapter had been written. Interestingly, the Bennett study or the Bennett review did show that there was an increase in quality of life, and that was statistically significant. And 3 of the studies that they included in their review at 6 and 7 months. So yeah, the evidence continues to build, but currently the evidence that we considered in the chapter, as I said, no more than promising. But what we were able to say, and this slide is actually was written quite clearly by Jill, the first author of the chapter. So if the evidence is promising, if it's more cost effective than a traditional home care approach, if the users are more satisfied, and I think there's clear evidence that that is the case, if there's no evidence of harm, then the conclusion that we made in the chapter is that reablement should be universal and system-wide adoption, and that there should be some really clearly agreed outcome measures that are used, and that more research continues to be needed to explore the impact of reablement on client level outcomes. So that was chapter 5. The second chapter that I'm talking about today is chapter 7. So this was reablement as a cost-effective option from a health economic perspective. And so the authors on this chapter were Magnus Singmark from Sweden, Hanne from Norway, and Alyssa Burton from Curtin University in Australia. And it's a great chapter that kind of explores some of the more fundamental issues around health economic analysis, and then goes on to look at some of the existing evidence on cost effectiveness of reablement, and then discussing health and economic perspective from both a clinical and a future research perspective. The chapter explored 8 studies across 5 countries, and concluded that there were few reablement studies that actually included a health economic analysis, but those that did, 4 of those studies found that reablement was cost effective, and the period of cost effectiveness ranged across those studies from 6 months all the way out to 8 years. And 3 of the studies that were included in the chapter found that reablement resulted in a reduction of health and social care costs over 2 or more years. The conclusion from this chapter was that reablement did appear to be more cost effective, and the authors referred to 2 systematic reviews of economic evaluations of reablement that reinforce that view, that reablement appears to be cost effective. And similar to the conclusion from our chapter in chapter 5, looking at client level outcomes, the authors concluded that larger studies are needed, and the outcomes that include costs related to health, social, and importantly, informal care costs should be included in future research. So across those 2 chapters, so the client level outcome chapter and the cost effectiveness chapter, the evidence shows quite clearly that reablement is not a one-size-fits-all, which I think really closely aligns with what Amy was talking about just now in terms of her chapter that she wrote with Rudy. Not all the outcomes relevant to everyone, but we do need an agreed set of measures, and so that's really clear. And service models differ. So even though reablement tends to have key features, as Hanne described, there are definite differences when you look at the research, and we need to be able to clearly explain those in research and evaluation. So a taxonomy of the elements of reablement, we need to be clear around that. And the randomized control trials, especially around client level outcomes, there are a few of those around, and some of the design has been questioned for some of those studies in systematic reviews that we looked at, and reinforcing, as I said, in chapter 7, the health economic analysis, that few studies include that level of detail, but it's really important that we look at that in future research design. So yeah, that's chapter 5 and chapter 7, client level outcomes and health economic analysis. Thank you.
Great, John. Thank you for this interesting review or attempts to assess, to evaluate the impact of reablement strategies in different contexts. I think that you were able to provide a very good overview of the book. Of course, this is a kind of preview, so the people have to go take the book and read it through it. But now it's time to go to comment and to discuss what has been taught here and also what has been written in the book. I'm very pleased to give the floor to Caroline. Caroline, thank you again for participating to this discussion. And we are really looking forward to your comments on that.
Okay, thank you very much indeed. This is quite a really special moment for me, because something like 15 years ago, we were approached by somebody from the English Department of Health asking us to conduct some research on a very new service called Reablement. And this particular civil servant was convinced it was a really important innovation. And I think back in 2008, 2009, we conducted one of the first studies comparing reablement with routine home care. And since then, there's been an absolute explosion of research into home care reablement. I've now been retired for about 10 years, and so I've been completely amazed by the robustness, the extensiveness and the robustness of the research and the interest in reablement across so many countries. So if you could move the slide on, please, Tina. Could I have the next slide? Thank you. So why, and also I was, delighted to be invited to comment on the book. So why it's important? I think it's got a clear theoretical framework, which I think some of the commentators contributors have already highlighted. It's multidisciplinary. It includes social gerontology, sociology, health economics, nursing, social policy, social work, even development studies. And that multidisciplinarity, I think, enriches the research evidence, and it generates new insights. The international comparative aspect of the book is really important. It shows that reablement can be successfully implemented across welfare regimes, whether they're Nordic, neoliberal, social democratic, and that even across those diverse welfare regimes, there are common policy goals or programme goals that emphasise maintaining or restoring autonomy. And probably for me, one of the really big strengths of the book is the robust, rigorous review of the existing research evidence. And I think, again, some of that has just been alluded to. So the book challenges some of the limitations of the evidence base. Of course, it is inherently challenging to demonstrate the impact of essentially personalised rather than standardised interventions. And I'll now go on to just illustrate some of the challenges and how important it is. I think that the book has engaged with those challenges. Can I have the next slide? So first of all, it's the whole issue of definitions. And I think one of the strengths of the book is to be able to continually refer back to the Delphi exercise and the construction of a consistent definition of what is meant by reablement. The second challenge, I think, is around the range of methodologies that different researchers have used. The most common ones are RCTs of different kinds, controlled studies, but also ranging from data linkage studies, prospective studies, and then more qualitative research involving interviews with service users and staff. A third challenge is around the evidence on the service model. And again, I think this is a real strength of the book, that the ways in which the services, reablement services are delivered, the external structures, the service frameworks that reablement interventions are located within. Again, these are really important because they help us to understand what does and doesn't work, what works better than another service. And fourthly, the book highlights the range of very diverse outcome measures that can be used, and we've already had references to some of those. So outcomes that could include quality of life, improved IADLs and ADLs, better health status, costs, and so on. And multiple outcome measures are an advantage because they can justify different political choices, but it does make it much more difficult to compare studies and to build a robust evidence base. In particular, the lack of incomplete evidence or really robust evidence on cost effectiveness could be seen by some as diminishing the value of the reablement model. But I think the book shows that other outcomes are also important and challenges a reliance on cost effectiveness and cost benefit as the most important outcome. So why does all of this matter? Why does the robust evidence base, the research on reablement matter? Could you move on to the next slide, please?
Sorry, it's a bit slow.
Okay.
I'll try again. Is this the one? Right.
Thank you. Yeah, brilliant. Thank you. Why does it matter? And this brings me on to, I think, some important reflections on the relationship between research and policy. Reablement can, at a superficial level, appear to be very, very attractive. It offers short-term interventions which ultimately have longer-term cost benefits. It leads to better physical and mental quality of life, cheaper, or it lowers sort of costs in terms of service use and greater user satisfaction compared to standard home care. And it has the potential to reduce demand for long-term care. And that makes it immediately, instinctively, politically very attractive. But I think the research also highlights that other outcomes are important. And particularly the desire for social connectedness, the recognition of our interdependencies, and that's a really important kind of counterbalance to the emphasis on cost. I think the research also shows that outcomes related to the workforce, I think particularly Tine's chapter on home care reablement in Denmark is important for this, because it shows the kind of unintended, if you like, benefits of reablement, potential of reablement in terms of workforce recruitment and retention, and the quality of jobs in the care sector. I think the research is also important because it shows policymakers and practitioners, gives ideas about how best to implement reablement services. It shows that reablement is best done with an interdisciplinary team, with specialist or trained staff, when it's not mixed with standard home care, and that professional skills, as I've said, have the potential to improve recruitment and retention. It shows that effective reablement requires the involvement of carers and family caregivers. It shows that reablement requires appropriate commissioning, payment, incentive structures. It critically shows the importance of continually adjusting and renegotiating the intervention in accordance with changing individual needs and circumstances, about being clear about the goals and about adjusting those goals as people's needs and wishes change. And it also shows that effective reablement requires a smooth handover and that ongoing support needs are met. So I think it's important, the book is important because it shows what is needed in order to deliver, as far as we know, an effective reablement service. I think also it's important to bear in mind that for future research, research ideally needs to be embedded within service design, aligned to desired policy outcomes and the research outcome measures. And I think there's some really interesting stuff there about timescales and the ways in which policymakers want instant results, but research will often take 6-12 months to you want to follow outcomes and identify outcomes over a much longer period of time. And finally, I can just talk a little bit about some of the gaps and where future research might go. So the final slide, please.
I'm pressing and pressing.
Okay. Okay, well, I'll talk, and if it comes up, that'll be good. Okay. So the gaps and where I think my views on the sort of priorities for future research. One of the things I think is striking about the book is that it brings together research, yes, from a wide range of countries, but they are relatively narrow in terms of their diversity. So I began to think, well, how would this model play out, and would it be acceptable in, for example, China, Korea, Japan, countries that have a very different cultural attitudes towards aging and older people, where cultural expectations are different. And indeed with sort of minority groups within our own sort of white Western cultures. So I think we need to be to fight to learn more about the kind of impact, acceptability and impact of reablement in different cultural groups, different ethnic groups. Secondly, I think we need to look a bit more at the wider organisational structures within which reablement services are embedded. So, for example, even within the countries covered by the book, we've got sort of integrated health and care services versus situations where health and care, long-term care, are very separate policy and practice domains. We need to be thinking about single purchasers, single providers, or purchaser-provider splits. We need to be thinking about what works best in terms of service commissioning and reimbursement arrangements as well. Do incentive payments work, or do they introduce additional distortions? And finally, I think we do need to be questioning the value of or the range of outcome measures, and in particular, the relative lack of importance given to outcome measures around social engagement and social activities. And I think just as part of that, part of the justification for that, I've been thinking about the evidence on the health impacts of isolation, the physical health impacts of loneliness, and whether or not those might counteract achievements and benefits in terms of improved ADLs, IADLs, and whether or not we undermine the impact of reablement because we're not addressing some of the things that are going to be really, really important to older people. So thank you very much, and I apologise for the confusion around the slides, and hope it hasn't distorted the programme too much. But thank you for giving me the opportunity to comment on the book.
Thank you, Caroline. Okay. I'm wondering if the editors of the book, maybe you need to, okay. Maybe Caroline, you needed to switch your mic on, off. Okay, thanks. I'm wondering if the authors or some authors would like to shortly react to Caroline before opening the floor. No? You prefer to take comments and then?
Can I just say thank you on behalf of editors and authors, Caroline. I think these were very insightful comments, and I do apologize for the mix-up in the slides. I hope it didn't disturb you too much. I think all of these comments are extremely relevant. I think these are comments that we have discussed and considered in the book. In the preparation of the book, and certainly something, many of these items is something that we need to investigate more time in researching. So thank you very much also for pointing out the research gaps. I'll also leave the floor to my co-editors and co-authors here. But while we just switching over to the more general discussion, let me just introduce to you the Reable Research Network website that I talked about earlier, where you can find more information about reablement restorative care in various countries. Very kindly, this is hosted by John, and you can find the link here, Reable Auckland, AC New Zealand. Also, if you're interested, there is now a discount for buying the book. So Policy Press offers a discount of 20%. I also entered the details into the chat function, but you need to use this code POTC 23 for achieving the discount. Okay, any co-authors or co-editors wanting to just comment on Caroline's presentation just before, or?
Yeah, I mean, I thank you, Caroline. I think it was amazing comments you made. I think the question around cultural acceptance of reablement, I think that's a really important issue that we definitely, as Tina said, we thought about when we were editing the book, because to this date, the most of the evidence is from quite a Western focus. So yeah, I think that's definitely something that going forwards in terms of service development and research and evaluation, I think that needs to be an emphasis.
Could I just respond to that, please, and just ask whether you're aware of any research that has, even within our own countries, has disaggregated samples and looked at different, for example, different ethnic groups within, within the reablement populations.
Yes, I mean, it's definitely been a focus in New Zealand. I mean, but we really do try to focus on our Indigenous population, our Maori population, and so it's often, in fact, any health research in New Zealand needs to consider the impact on Maori, and so that is definitely something that we've explored in New Zealand. Yeah.
Okay.
I also
See,
just
Amy, I
wanted
think
to-
Amy, do you want to follow up at this point?
Yeah, and actually, I
Yeah.
wanted to continue on the same point for a brief moment, because I believe in the Buma et al. Review that they discuss some research, preliminary research coming out of Taiwan, and it's still kind of reablement-like, but at least it was the first sort of Asian version of reablement that I was aware of. And I met recently with some social care researchers and practitioners from Hong Kong. And I think there the discussion was very interesting because, to your point, Caroline, it's very important to take into consideration these cultural contexts and the family context, because their care provision services are so much driven by either private organizations or the family, and there's so much that has to be negotiated between those two entities, you could say. So I think that if reablement were to branch out to some other countries, the informal care networks and the family relationships would have to be very, very much taken into consideration. I think one of the reasons why reablement is so successful, or at least has become so widely implemented in high-income Western countries, is because of these kind of welfare state political organizations and the type of service provision coming from these more formalized networks. So it was an easier way of implementing the services in these particular types of countries, but I think the cultural context is really important to explore as reablement spreads.
Sure. Okay. Thank you, Amy. Okay. We have a couple comments from the other people attending the meeting, so I think that it's better now that we give the floor to them. I think that Anne Merlendal, she raised the hands.
Yes, well, thank you very much.
Are you around? Okay.
Yes. Well, thank you very much.
Please.
Thank you, Costanzo. Thank you for this lovely presentation and this book that I'm looking forward to read. Very intriguing and quite interesting, and also quite quite interesting results, and also thought-provoking in a sense. I have two questions, and I haven't put, I mean, you can decide who wants to answer them. The first one is about reablement being very popular, being on the political agenda, and there are a lot of policy logic sort of supporting reablement. But one of the things that you don't mention, at least in your presentation, maybe it's in the book, is the issue about professional drivers. Are there sort of, professional interest in also driving this agenda forward? And I'm thinking about, professionals like therapists or physiotherapists, and how they might have an interest in driving this agenda forward. And I'm just missing some reflections and how that sort of also, I mean, they're both advantages and drawbacks, because of one could also see it as an advantage that part of care work that is usually said as non-professional now becomes more professionalized. It can enhance a professional identity. It can either supplement care work or replace it. But I'm just interested in how you view the issue of professional interest as drivers. So that was the first question. And the second question relates to the issue of the recipients or the co-producers of reablement, the elderly people. in research we did more than a decade ago in Denmark on reablement, we had instances where elderly people were resisting reablement. And we also had experiences where research assistants, when doing observations of reablement, were actually ethically concerned about whether what was being done in the situation was right or wrong, or whether it was actually crossing some boundaries. So the issue is also whether in the research you have done or in the reviews you have done also have looked at issues of harm, because as John said in his last slide, it doesn't seem that there is actually harm being done. However, there are instances in some of the research done earlier who actually shows that some harm is actually being done. So I just wonder how you reflect on these issues of reablement, ethics, and where, you know, the state and the professionals are actually disciplining some elderly who don't want reablement or resist it, or would rather like to sit alone and read a book, for instance. So I'm just concerned about these issues, but I'm sure you probably have dealt with it, but I would just like to hear your thoughts on that. Thank you.
Thank you so much.
Can I address?
Sorry.
Okay, go ahead. Please take in account that we have more comments in the chat. So be very short, please, in order to give the people the chance to make questions. Tine, please.
I think John was first wanting to address.
John, you okay? Go ahead.
Okay, in response to your first question, Hanne, buy the book and have a look at chapter 4, because I think when we look across implementation of reablement across 5 countries, it's apparent that the professionalism and the professional drivers and the facilitators of reablement actually are different across different countries. In New Zealand, reablement has always been and remains very much a nurse-led model. And obviously in Scandinavian countries, there's a very high, it's often driven by occupational therapists and other allied health. And so hopefully that chapter will be thought-provoking for you in terms of the different ways that professions have positioned themselves in driving reablement.
Okay, Tine?
Yes, I just wanted to address the same point and agree very much with John.
Okay.
It really depends on the context. But I think within the Nordic countries, what we have seen is that it's very much driven by occupational therapists, and that has also introduced a whole new approach to what is the outcome, what is the language that we use. I think the Nordic research has established that it has created a change also for those who normally provide home care. These would be social care professionals. But it's also created perhaps a recognition of their role in being the one who's closest to the recipient, and also having a valuable insight into the recipient's preferences and wishes. But I think one of the concerns which we also address in the book is, with this change and more emphasis on the OT approach, there's also aspects of also that Caroline addressed in terms of social engagement. What is the value of the social contact and so on, which seems to be disappearing in some way. So it's a devaluation of the more traditional social care approach that we have normally had in the Nordic countries. Thank you. I was thinking, Amy, maybe you wanted to address this with the recipients, because I think that's very much part of your chapter.
Yeah, I just raised my hand to kind of follow up on that exactly. And we addressed it in the chapter, but I also addressed it in my book, which was based on my PhD dissertation. And Hanne, you don't know me, but I'm based at the University of Copenhagen, and I did a qualitative study that was following a lot of different health professionals with their work through with elderly people in a particular municipality. And I think it points to exactly these challenges that you're raising, that when the state has certain expectations, when the government has certain ideas about what aging should look like, and how do the health professionals interpret that kind of discourse and implement it in practice when they're actually working with people. And what I found in that work was that, you know, the health professionals really struggle with exactly these ethical dilemmas that you're pointing to, because they feel very much challenged by their directive by the municipality and the departments that they work for. I was following a very new team of reablement professionals at that point. And the older people themselves often feel like, well, if I don't do this, then I won't get the services that I want. So they feel an obligation to perform a certain way and to go through these reablement programs or any sort of service that's being offered by the visitation services, preventative home visits, or the reablement therapists. So I think it can be extremely challenging from a user perspective as well as a health professional perspective, because they're having to negotiate these things in everyday life. And I think what my chapter in this book gets to is that there's a way to make this, we believe that there's a way to make this whole negotiation easier for everybody by just really focusing on the goals and context of the older person, and focusing less on what the government officials may want for healthy aging and for citizens.
Okay, I see also handsman. Any hands?
Yes.
Hand?
Yeah, I wanted to add a comment to the thing about is reablement doing harm to clients, and there's been some research from Denmark in particular, or I think only from Denmark in this respect, documenting that it has been doing harm, and that is, I think that is also related to that reablement is part of the legislation in Denmark, and they are all the people applying for home help are suggested to have reablement, and they are directed towards goals which are in self-care, because they want the policymaker wanted to be independent in cleaning their houses. So this has, of course, ethical concerns. However, it is not the same case in Norway and other countries that it's like that. So in general, and from my country, we have a lot of research, quality research on users and also on professional. And the general impression is that they are very satisfied with the service provided, both the providers and the older person themselves.
Thank you so much. Thanks, Anne-Marlene, for your provocative comments. There is a lot of discussion in the authors. We have a very long comment from Yolanda. Yolanda, do you want to take the word and just to express your comment by yourself, or do you want that we read it?
I can do it myself.
Yeah, thank you. Yes, thank you.
Summarizing it, it kind of means that, so in the Netherlands, reablement is also a very popular approach. And talking about it with older adults, they do have the feeling that it's somehow another imposed policy measure to save cost instead of something that may benefit them. And I was wondering whether the authors of the book might have suggestions on how reablement might work to bring it closer to the livelihoods of older adults, to prevent this kind of discursive annulment of reablement as something that may actually help older adults.
Okay, do you want to keep this in your mind and then we go on, or do you want to react? Hanne? I know, was...
No.
No, okay.
There was an old hand.
Well, maybe I can address it and I say I recognize very much your concerns from the debates that we also have in the research community in Denmark, because it is aligned with a cost containment agenda. So you have like you have the principles of reablement, and then you have the daily practice. And we see more and more that the local municipalities have cut the cost, are reducing home care. And it seems it's becoming reablement is sort of the emphasis on reablement is not the same, I would say, as when it was introduced in 2007 and introduced in the legislation 2015. Quite interestingly, we just had the health authorities making a new policy on how to make a reablement person-centered. And I was thinking, isn't it person-centered from the beginning? But I think these are some of the concerns that it's been increasingly used as a way of trying to make people, as Hanne said, independent in their cleaning and not needing the services from the community or the local community. So I think it's very important to see the reablement policy and practice embedded within what takes place elsewhere. In terms of the rights to receive services, and what's also the quality of these services, and what's the level of the services. So it's on paper, I think I support very much this approach, but when we see it implemented in reality, it's implemented in very different ways. And that's interesting, as Hanne said, just across Norway and Denmark, it seems to have a quite different emphasis and also outcome.
Thank you so much. I say Amy and John. Amy?
Thank you, Costanza. Yeah, and thanks for the question, Yolanda. I didn't have time to get into it here in the presentation, but one of the things that Rudy and I point to at the end of our chapter is that a model that we can start to look at for inspiration on how to move away from this kind of discourse about active aging and healthy aging and all of that. We point actually to a Dutch model called buurtzorg. I'm sure you're familiar with it. It means neighborhood in Dutch for everyone else. And basically it's based in nursing care, but the idea is that it focuses on the client's living environment, the people around the client, and their informal network. And a key element is that the health professional should have a sustained focus on the opportunities in care, as well as the local community that exists to support the citizens' autonomy and self-help. So it's meant to be a small person-focused team that really is familiar with the local context around where different clients live, so that they can integrate them and help the older person become more part of that local neighborhood and local community. So we describe in the book why we think that could be a helpful model to gain inspiration from. And I know in Denmark, at least the buurtzorg model has already started to become piloted in some different municipalities. So it's a relatively new thing here. It's only been within the last couple of years, but I think it's promising at least to look at as a form of inspiration for how to focus much more on people's perspectives in a local context.
Okay, thanks. John, please.
Yeah, thanks for your question, Yolanda. I think it's a really, really good one. I think one way of measuring that issue comes back to one of the points that Magnus and the other authors in the health and economic chapter raised, and that's we need to consider, in terms of costs, we need to consider informal costs as well, because if reablement is being used as a way to reduce formal costs, then that will have a knock-on impact on informal costs, because if the older people are having to rely on family and friends more, so I guess it just reinforces the importance of making sure that evaluation and research considers informal costs to reablement as well.
Okay, I see David's hand and Tina. David?
Yeah, I wanted to pose a question, but also remember, Costanzo, there is a comment by Bo Jung.
I know that.
Okay.
Yeah, okay.
Okay, thank you. I was taking the opportunity. So I was just wanted to comment on the last comment of Amy and also make a question regarding buurtzorg. Looking at a comparison between Denmark and Spain, what you see is that buurtzorg can be implemented without any type of reablement discourse. It just overlaps with existing reforms. So in Denmark, it's funny because you were seeing in the interviews how the reablement discourse was in my interviews about buurtzorg as a way of helping reablement, but it can just be not in the discourse at all in other contexts where reablement has not started, as in Spain, where attention centered around the person is the thing, but not reablement. That's not the thing I have heard of. And I wonder, maybe here come my questions. I wonder two things. One is the idea of integration of services that has already been touched upon. Are systems that are more integrated more fitting for the reablement discourse to grow? Whereas when you have like to separate social services and health, then the reablement doesn't make any sense because there is no this strong health part. And then also in terms of comparative differences about how we frame, sometimes we say users, sometimes we say clients, sometimes we say in Denmark citizens. Does it all these discourses also affect at the end practice, or do you think this is just words and at the end we can just see across, it doesn't matter that much?
Okay,
thank you.
Thank you, David. Thank you for these comments and questions. Tine,
maybe I can make a small
integrate this.
Maybe you can make a small commercial for David because he's handing in his PhD very soon, and this is about Busorg. So and this comparison between Denmark and Spain. And thank you for bringing that up, Amy, because I think that's so interesting from a Danish perspective, because we can see it rolling out now. As we had in the period from 2007 to 15 with reablement, we now have a new trend fashion, and this is Busorg, and everybody needs to do it. So I'm a bit concerned about these quick fixes, to be honest. And I think often it's devaluated because the fundamental idea, like with reablement, is kind of lost. And you seem to be doing the same things in the same way. But I do, however, see at least Busorg, the way it's implemented in Denmark, is more like the organizational model with fixed teams of professionals. But to David's question, I think yes, therefore also Busorg is often implemented without reablement. So the two ideas don't necessarily go hand in hand. And I'm really afraid that we are losing the idea of reablement because we are now so focused on Busorg and the fixed teams idea. Your question about the integration of service, and I think here you also thinking about at least the way we organize it in Denmark. You can have a team providing reablement, or you can have it like integrated in the home care staff as such. And our finding is that it's more effective in terms of introducing and maintaining the fundamental ideas of reablement and the practice of reablement if it's integrated in the whole team, also including those working with home care. Because often after you've received a reablement intervention, and then the routine home care workers come and provide services, and they don't have the same approach. So that's definitely a benefit, I would say. Thank you.
Okay, maybe before giving Amy the floor, I would like to read a comment which is in the chat, which is in some way related back to the point about diversity.
Sorry, Costanzo, my comment was just really quickly in response to David. So if I could just quickly.
Go ahead.
Thanks.
Okay, go.
Yeah, so I think Tina explained it very well in terms of the integration of services, and a lot of the work that I'd done earlier with reablement professionals and with the municipal health professionals more generally. It was about this, how do we integrate and what services? And it was a lot of scheduling issues. You know, it has to do with when people show up at an older person's home and they're scheduled to work a certain number of hours and they have their holiday at certain times. And there was just a lot of coordination that had to happen in addition to considering how to integrate and make this reablement or any type of service, home-based service, more effective for older people. And the older person often wanted to have continuity in terms of the same people showing up at the same time every day, but that was incredibly difficult for the health professionals to do in practice because they had all of these other things to manage at the same time. So I think that still remains, at least in my experience, that remains a challenge for how the services are actually organized. But I also wanted to comment very quickly on your second point, which is about the terminology. And I think it's a really important point because words do matter. And, you know, regardless of the language we're speaking, and I know a lot of the health professionals I worked with said, yeah, well, we've gotten away from talking about older people as clients because they're not buying a service from us. They're not buying a product. So we think of them as citizens. We think of them as active people within the community. So they were, in that particular municipality, they were choosing that phrase, that way of talking about an older person, because to them it represented something meaningful. So I can't speak to a lot of other places, but I think there is, at least among the professionals, a discussion about which words to use.
Okay.
Thanks.
Thank you, Amy. And there is a very interesting comment from Bo Young Kim. I don't know if this person is, maybe you wanted to say by yourself, or do you wanted that we read it? Hello,
yeah,
Bo Young.
You can read what I wrote.
Okay, thank you. Do you want? Would you like to just introduce yourself?
Actually, I will have opportunity to explain about reablement to public servants in Ministry of Health and Welfare in South Korea. And but what concerns me, because this policy can be really good strategy to deal with excessive institutionalization issue in South Korea. But what happens in South Korea, we have a very strong tradition, comes from very fast economic growth, more focused on individual responsibility for their own welfare. So in that context, the reablement policy can be used to say to older people, if you don't want to go to the institution, then we will train you to deal with your own need rather than support proper social care services. So what kind of advice you can suggest to prevent that happening in South Korea?
Oh, thank you so much for your question. There is one more point that you raised in your written comment, which I think is very interesting, because you said something more. So your question is also about, what about developing reablement in a context where the rights to care of people are not really in some way recognized? So what happens in this kind of context? Because this could become in some way something that can be not really helping the people, but maybe helping more in some way, to give more importance to policy issues than just to the issue of helping people. So I think there is something more profound in the comment that you did, but very interesting. So I don't know if some others. Tine, yes.
Yes, thank you very much for addressing this very important question. And I think this is a question that we need to address in every welfare context. Even in the Nordic context, where, as you say, or you don't say, but you emphasize there are differences in the social rights. We don't have a right to receive services. We have a right to be assessed for care needs. But I think this very point that you make is so important, because it's also part of the active aging paradigm that we want to put some responsibility on the individual in that sense. And Reablement has the dangerous potential of emphasizing that paradigm and that approach, I think, and we need to be really careful. But I also choose to put on the positive hat sometimes and think that it's in the way that it's addressed and presented, it's also part of the social investment agenda, trying to tell countries, welfare states, that there is an idea in investing early, because this is actually possible to prevent persons from deteriorating their functional ability and so on. So it's a way of helping, assisting, facilitating that people can live independently, but it needs to be connected with the right to receive the assessment for care and some services. So, but thank you very much for raising this.
Thank you. I see Hanne. Hanne,
yes,
please.
I wanted to fill in there. Very interesting to have a person from South Korea. I know there's been one Reablement publication from South Korea. I don't know if you were involved in that one, but I know that in other Asian countries, in particular in Taiwan, Reablement is more implemented more widely, and there's also one publication coming from Japan. So it's not, Asia is coming up as it seems. The difficulties they are faced in Taiwan is that it's more than our European country based on informal care, and also the care provided is hospital based. There is very little home-based care. So when they have implemented Reablement there, it's primarily in nursing homes or in hospital settings, whereas elsewhere it's in home-based care. So that's, I don't know if that's is relevant for you the same way, but that's the experience from Taiwan. Thank you.
Okay, any further or any comment? Okay. Okay, I think that time is over. There are some more comments in the chat that people congratulating with the editors and the authors of the book. Some people said that they are looking forward to reading the book. So I think that the discussion was really helpful also for the people to understand better why the book is interesting, is important. Thank you to all of you. I thanks also the people, the attendees who took the floor, tried to explore, to express some comments and questions that were very helpful for our discussion. Thank you so much, Caroline, for your very helpful comment to the book. I think that the editors and the authors enjoy a lot. Also, of course, when you mentioned what is in a way for the next research to be done on this issue, of course. And okay, I remember that the discussion, all the seminars has been recorded and will be published on some public channels in the future. If you have anything against this, please let us know. Otherwise, we will try to make it public in order to make other people who were not able to attend this morning able to listen and to understand that. And also that the Data Transforming Care Network as a membership that you can have very easily to go on the website and to take some we spread out on the people who are members of this network. This is only a network, so we don't ask so much to the people, but only at the beginning just to be members. That's all. I thank also David for the excellent technical assistance and also for the comments. Thank you, David, for help. So, okay, see you next time and enjoy the rest of the day for the people who are from the Western countries in Europe, and enjoy, I think, also the evening for the people who are on the east of the world. Okay. Thank you so much.
Thank you. Thank you very much
goodbye.
indeed. Thank you. Bye-bye.